Well, good morning and welcome to University of Wisconsin Department of Medicine Grand Rounds. It is my immense pleasure to welcome to UW Grand Rounds Dr. Alexis Ogdie-Beatty. Dr. Ogdie is an exceptional tenured associate professor of medicine and epidemiology at the University of Pennsylvania Perelman School of Medicine. She's in the Division of Rheumatology. She received her bachelor's from University of Minnesota. She received her MD from Georgetown, and then her master's during her internal medicine and rheumatology fellowship at UPenn. She now serves as the director of the UPenn Center for Clinical Epidemiology and Biostatistics, and also as the director of the Penn Psoriatic Arthritis and Spondyloarthritis program. Her mission is to improve outcomes in psoriatic arthritis by accelerating diagnosis, increasing focus on meaningful patient-centered outcomes, and developing and advancing methods for precision medicine. And as a physician scientist, she's built an exceptional research program that is really spanning from bedside to global population health, and she has over 130 peer-reviewed publications. She's been invited to lead and present her research at many national and international conferences. She's chaired the American College of Rheumatology early investigator subcommittee years ago. I think that might have been one of the places we interacted, and also chaired working groups for the OMERACT patient outcomes group, the National Psoriasis Foundation, and she sits on 5 editorial boards and many study sections, including the NIH and IM study section. She's also received multiple awards, including the University of Pennsylvania's Distinguished Faculty in Epidemiology, the Bowman New Investigator Research Award, and she was recognized in 2020 and again in 2021 as the top US expert in psoriatic arthritis. She's enthusiastic, she's visionary, and she's a leader in psoriatic arthritis, including clinical trials, all the way through kind of thinking about population approaches and strategies. And I'm thrilled to hear her talk today as she presents the road to prevention of psoriatic arthritis. So I hope you'll go ahead and welcome her with me. Thank you.
Thank you so much for that generous introduction. And most people don't actually read the CVs. And as a graduate of University of Minnesota, University of Wisconsin has always felt like my cousin. So I am happy to be here today. And thanks so much for the invitation. All right. So today I'm talking about a concept that's a little far off in the future, but we're going to pave the way and show how we're getting to that future time point. These are my disclosures. I also work with a variety of different groups. All right, so the topics we're going to talk about today are summarizing the clinical presentations of psoriasis and psoriatic arthritis. As a medical grand rounds, I thought it'd be nice to kind of step back and talk about what are these conditions that we're talking about. Examine risk factors for psoriatic arthritis among patients with psoriasis, and discuss strategies to reduce the incidence of psoriatic arthritis in patients with psoriasis. So I'm going to start with a patient case. So a few years ago, actually about 5 years ago, my dermatology colleague, who is just on the other side of the hallway from me at Penn, Joel Gelfand, had a patient with psoriasis, and this guy was complaining of toe pain. So this is a picture of psoriasis, by the way, on the scalp, which is one of the more common areas for psoriasis to appear. And then also it affects the nails. You can see those nails there. He's got some pitting in these. It looks like someone took a little pin and just pushed into the nail. And then also there's this kind of lifting of the nail, which we kind of call onycholysis. So it looks like it's just kind of lifting up from the nail bed, like someone pushed it up underneath the nail itself. So this patient had some nail psoriasis, and he also had a little bit of scale psoriasis and this toe pain. So Joel sent him to me and said, you know, he's having some morning stiffness. Is this psoriatic arthritis? So I saw the patient, his toes looked perfectly fine. There was nothing to really see on exam. He was saying, this comes and goes. I take a little naproxen and it gets better. And so I said, you know, I don't see anything yet, but let's just see you once a year to see if there's anything going on, and let me know if you develop any swelling. Well, being a early 30-something male, he never came back. So he was being seen intermittently as needed by dermatology. And so, but one day Joel called me again and say, hey, I have this patient who has some toe swelling. Can you run over and look at it? And so I wasn't able to run over and look at it, but I saw him very quickly after in the clinic, and he had dactylitis of his toes. And lo and behold, it was this exact same patient. So it's kind of interesting, because what if I was standing there 5 years ago and I knew that this guy was going to go on and develop psoriatic arthritis? Could I prevent that from happening? Is there something we could have done at that time point? Or was there even a way to know that that was developing? Because it sounded, the history sounded pretty good for psoriatic arthritis, an inflammatory symptom, maybe a feeling of swelling, even though I didn't see any swelling at the time, and that stiffness in the morning when he was first waking up, and improvement with NSAIDs. So if I would have known that, would I have changed my management at the time? Would I have maybe started him on a therapy? The answer is no at this point in time, but this is one of the questions that we want to ask is, can we say this patient is developing psoriatic arthritis or is going to develop psoriatic arthritis, and then maybe consider management changes that would improve the long-term outcomes for that individual patient? So speaking of dactylitis, dactylitis is swelling of an entire digit like a big sausage. And this is a picture of someone with dactylitis. These are Google images, not my patients, but so you can see this nice big toe here. And one of the ways you kind of know is dactylitis is you look on the other side, and this toe looks a little bit different from this one. This one looks a little bit different from this one. And those may have been more red when they first got started, but then the redness kind of goes down and the swelling remains. The swelling can actually remain for quite a long time. So these guys might feel a little squishy and tender, but in about 6 to 8 months from now, they may still look larger, but they might not feel as squishy, and they may not be as tender. And then we call them kind of cold dactylitis because it's resolved. But unfortunately, that leaves the deformity. And so then that changes how that patient might feel when they're running or when they're walking and feel what's underneath their toes. All right, psoriasis. Everybody in here has seen psoriasis. Psoriasis is a very common skin condition, affects about 1 to 4% of US adults, depending on who you ask or what data set you use to calculate the prevalence. Psoriasis, the key features are that there's an erythematous base, there's induration of the skin. So if you run your fingers over it, you can feel a difference. And then there's scaling on top that looks a little silvery. So the silvery scales you kind of remember from medical school. But also that is well demarcated. Sometimes it's really hard to tell the difference between psoriasis and eczema. Even dermatologists struggle with that sometimes. And SIBO psoriasis or seborrheic dermatitis on the scalp can be hard to differentiate too. But psoriasis, typical plaque psoriasis, has nice, well demarcated borders. I also show this picture of these tiny little lesions because these can throw you off a little bit sometimes. But these are smaller little psoriasis lesions. And again, you see that they're pretty well demarcated and they have a little bit of silvery scale on top. Guttate psoriasis can be really difficult to pick up sometimes. And that's that little kind of pinpoint lesions all over that eventually do coalesce into more plaque-like psoriasis. And they can be really red. So psoriasis essentially can look like many different things, but has the same key 3 characteristics: erythema, induration, and scale. Now, there's also one other important point to remember when you're thinking about psoriasis is that it does look different on darker skin. So as the skin gets darker, that erythematous component starts to be less apparent and it looks more hyperpigmented. So don't let that throw you off. We do know that patients who are Black or African American or have different darker skin tones can be underdiagnosed because it's just not as obvious sometimes. So this is another common area, again, on the scalp. So right up here, so this is a pretty impactful area, you might imagine, that people don't really like walking around with their scalp psoriasis like that. And this can also be painful and itchy. So it can burn, especially when they get certain shampoos or hair products on it or facial products. But it's also itchy, and this will keep people up at night itching. Some people talk about in the middle of the night, we're waking up with blood streaming down them because they've been itching all night in some areas when the psoriasis is really bad. So beyond the dactylitis that I showed you, psoriatic arthritis is a highly heterogeneous inflammatory arthritis. So rheumatoid arthritis we know quite well, or at least we talk about a lot, and it's a little bit more prevalent. So the prevalence of rheumatoid arthritis is around 1% of US adults. Psoriatic arthritis is probably around a quarter percent of US adults. And when you combine in the other spondyloarthritis, it may reach up to 1% of that whole group altogether. So psoriatic arthritis can have peripheral arthritis, can look like RA for all practical purposes. It's associated with enthesitis or inflammation where a tendon, ligament, or joint capsule inserts onto the bone. So this was one of my patients where it was really obvious. It's usually not this obvious. Usually you're kind of pushing for tenderness and really putting an ultrasound probe on there to see if there's inflammation where the tendon is inserting onto the bone. But in this case, my patient actually had some fluctuance there. So I was like, can I take a picture of that? We don't see that very often. So dactylitis, this is kind of an exuberant dactylitis with lots of erythema. The nail disease that I showed you, when people tend to have very severe nail disease, they can often have DIP arthritis as well. But in general, DIP, inflammatory arthritis, is one thing that differentiates PSA from rheumatoid arthritis, because in RA, they don't get DIP involvement. You can in osteoarthritis, however. And then this is a syndesmophytes along a spine. We don't see this very often anymore, but this is to point out that axial spondyloarthritis is also associated with psoriatic arthritis. So axial disease is one component of PSA. And this often begins in the sacroiliac joint. So they might talk about hip pain is one of the more common things I hear. It's really their posterior hip or their low back when you kind of ask them to point to it. And it can be on both sides. And this is associated with stiffness in the morning when they first wake up, does feel better with NSAIDs. Still really difficult to differentiate from mechanical back pain often. All right, I talked a little bit about epidemiology already. One interesting thing is that the male to female ratio is about 1 to 1. So in RA, it's much more female predominant. Axial spondyloarthritis tends to be more male predominant, although we're seeing as we are identifying that non-radiographic group who don't yet have X-ray changes, there's a lot more females in that group. So it's getting closer to 1 to 1. And the age of onset varies widely, but is in the 30s to 50s in general. So these are pretty young people. Often after a delivery of a baby, for example, or around the time that they're getting started with their careers, and there's lots of stress and other things going on. So one of the most exciting things about being in this field is that there has been so much progress, especially over the last 20 years. So psoriatic arthritis, psoriatic disease treatment has come has had substantial progress. So back in 1964 was the first time that psoriatic arthritis was defined as a disease. They came up with some criteria. Sulfasalazine, the first trial for psoriatic arthritis was in 1990. And then in 2002 was the first trial for a biologic. And since then, we have all these different therapies, including recent new approvals in 2020 and 2021 and 2022. So this is now what our treatment landscape looks like. So we have a lot of therapies. We have oral small molecules. So these are the ones that are traditionally used for rheumatoid arthritis, like methotrexate, sulfasalazine, luflanomide. Some different ones are apremilast. That is one that's used specifically for psoriasis and psoriatic arthritis. None of the ones in the oral small molecule box actually have disease modifying properties in studies. So they may, but we just don't have studies to prove that they do. And so we're trying not to call them CS-DMARDs, which is a term, or DMARDs that we use in rheumatoid arthritis all the time. And then among the biologics, we have the TNF inhibitors. There's 5 of those. There's IL-12/23 inhibitor, ustekinumab. There's interleukin-17 inhibitors, and this is one of the fastest growing classes. So you see commercials for these all the time. But there's secukinumab, ixekizumab. There are a couple. Bimekizumab is now available in Europe and should eventually be available here in the US. Brodalumab is only available in psoriasis. And there's 2 more that are coming in psoriasis and psoriatic arthritis in the near future. Abatacept is approved for psoriatic arthritis, but not often used. And then we have JAK inhibitors. So we have 2 approved JAK inhibitors in psoriatic arthritis, not approved in psoriasis. Deucravacitinib is a brand new mechanism of action called the TYK2 inhibitor, and that's approved in psoriasis, but not yet psoriatic arthritis, but eventually will be as well. And then interleukin-23 inhibitors, guselkumab and risankizumab, and then tildrakizumab is one approved in psoriasis, but not yet in psoriatic arthritis. So wow, that's quite a list of therapies. And if you went to medical school when I did, none of these were on our tests back then. So now some of the medicine, we actually don't even give all these to the med students because we don't want to overwhelm them. So lots of things that are going on in medicine. And one of the interesting things is that if you have axial disease, only 3 of these classes are for you. So the TNF inhibitors are for your patient, I should say, IL-17s or JAK inhibitors. So we don't use the other ones for axial disease. This is a change from the more distant past when some of those oral small molecules were sometimes used. We don't use those anymore for axial disease in particular, but you can use them for peripheral disease. So I just got done telling you about all the amazing things that have happened. But unfortunately, when you look at the numbers, the TNFs were the biggest change. So that was 20 years ago. And our individual therapies haven't actually moved past that original bar from the TNF inhibitors back in 2002. So in psoriasis, they've made substantial gains. So those back bars there, this is the 90% improvement in the psoriasis, the body surface area. Those IL-23s have just kind of blown that out of the water from where we used to be. So psoriasis treatment is phenomenal now. We can clear a whole body of psoriasis in a relatively quick amount of time. On the other hand, for the arthritis, we can get people better. So this is an ACR 50 or ACR 70 response, so 70% improvement. So about 20%, up to 20% of people on a TNF inhibitor can get a 70% improvement in their arthritis. But there are no other classes that have hit that same level. IL-17s more recently than when we published this, but there was a head-to-head where they did the same, but still not better. So we lag quite a ways behind in the treatment of arthritis compared to the treatment of the skin disease. Why is that? Well, first of all, we might just need new therapies. We might not still fully understand why inflammatory arthritis is happening in the joint, and what's happening when it gets started is probably different than what continues it. And so if we treat like we're starting when it got started, it's going to be a different paradigm that's needed than when it's 2 years down the road. So we have to learn more about that and have therapies that address that. Additionally, this is a highly heterogeneous disease. I showed you all the different features of the disease. Many people have different subsets of disease, and we haven't fully learned how to cluster and subset those. We have all of these therapies, but we have no idea how to use them because all we have are the industry-sponsored trials, and we're working on getting new trials up to get head-to-head comparisons so we can understand how to better utilize these drugs. But right now, we don't have that evidence. And diagnostic delay. So many people know about rheumatoid arthritis, and primary care doctors are really good at getting rheumatoid arthritis in to see a rheumatologist. Psoriatic arthritis is harder. It's got this stumbling start. You don't always see it. Sometimes in the beginning, it kind of comes and goes. And so then it throws everybody off. And the people might not go to the right doctor the first time, or they may be seeing the podiatrist who is giving them toe injections for this toe swelling that they're having and not quite sure why it's being given. So there's still a diagnostic delay that we have to do better at. And finally, we've been studying psoriatic arthritis as if it's rheumatoid arthritis. And I think as we've gone on, it's much clearer that these are two very distinct diseases, and we need new paradigms to study psoriatic arthritis in trials as well. But today I'm going to focus on this diagnostic delay part. I'm going to come back to that patient that I had that essentially had a 5-year delay in diagnosis from when he started experiencing symptoms. How do we shorten that? And how do we think about treating earlier in that cycle? So are there any dermatologists here? No. Okay. So, I mean, it's medical grand rounds, but just in case. So, so the dermatologists hate screening questionnaires in general. So when we talk about this, it's good to know if you're talking to a dermatologist in the room. So we have screening questionnaires for patients with psoriatic arthritis, but to utilize those, that means that for the dermatologist who's seeing 40 patients at a minimum in a day, and they all have different diagnoses, of which maybe a few have psoriasis, where they have to give a questionnaire to just a couple people, interpret the questionnaire in that very short period of time, get them to see a rheumatologist who here you have much better waiting time than we do. But to get into the rheumatologist, then it takes conversation and going back and forth. And so dermatologists don't like screening questionnaires, and that's probably the most captive population to get. One of the questions that we've had is, given that we have a medical record, can we utilize our medical record to directly screen patients? And so between Utah and Penn, and NYU, we've done an initial study where we randomly selected patients with psoriasis. And then among the randomly selected group, we sent half questionnaires through the EMR and as a letter, just in case they didn't utilize the EMR. And then we also then we monitored the other half. Then among the people that we sent questionnaires to, we randomized the way that they would get into the clinic if they had a positive screening test. And what we found is it was really different at each site, what happened in particular Penn and Utah. At Utah, they didn't get a lot of people calling the clinic. And at Penn, we got a lot of people calling our clinic. And I don't know if that's because there's differences in amount of chronic pain in the situations, or if it's that the wait time is so much less at Utah, they could just get an appointment if they needed to. But at Penn, it's really hard to get an appointment. So what we found, though, is among the many people that we did see and we did screen, none of them had psoriatic arthritis. So it wasn't really an effective way of picking up the disease. We made some modification sense, and the next round is going to go out soon. So we'll see if modifying the tool can help. But as rheumatologists, with diminishing numbers of rheumatologists, we can't have something with a really low sensitivity. We need to have more we need to have, we want something with lower sensitivity, higher specificity. We can't take the high sensitivity test that's going to bring everybody into us because we don't have that capacity. So this is still a work in progress, but it might be one thing we can do. Another thing we've been doing is we've developed an app. So the Psorcast app, Psorcast, so like forecast. The idea is that it uses some of the movement ability within a phone, so the gyroscope and the accelerometer, to be able to capture walking. So you can do a walking test and it captures the amplitude of someone's walk and sees if it changes over time. Additionally, there's some manual tests. You can check the range of motion of your wrist, for example, and they can see if that changes over time. And there's essentially a walk test as well, like a 6-minute walk test. So that's another option, is going direct to the patient and offering some more specific things. That's still in a validation phase, but maybe down the road, we can utilize technology to help us with this as well. But what if we change that question around? What if we say, we know the majority of patients with psoriatic arthritis develop psoriasis first, about 60% or so will develop psoriasis and have that for a while before they develop the psoriatic arthritis. Can we actually take those patients that are at high risk, identify them, and treat them for their psoriasis prior to the time they develop psoriatic arthritis, preventing or at least delaying the onset of PSA? So there's a number of key questions that have to be addressed, and we've been working on this over the last several years. Who will develop PSA? So can we develop risk scores that identify those people? How do we know when it's happening? That's actually that, back to that patient that I saw. How did I know? How would I know that it was happening right then? And does treatment of psoriasis mitigate the risk for PSA? So we have this group called PAC-MAN, Psoriasis and Psoriatic Arthritis Clinics Multi-Center Advancement Network. It's a group of dermatologists and rheumatologists working together to figure out how we can improve the care for psoriatic disease and how we can accelerate diagnosis. And so we've kind of, as a group, done a lot of different studies, but also kind of got people together in a room to think about these things. One of the things we put together first is a concept, like how do we want to think, how do we need to think about this? And fortunately, rheumatoid arthritis has been thinking about this for a while, about how do you identify people who are developing RA. So the concept is that patients have psoriasis and they probably have some innate risk factors like genetics, for example, or maybe it's that they're obese. We know that obesity is a really strong risk factor for PSA. And then there's some second hit along the way that stimulates the inflammation in that susceptible host, kind of like a cancer 2-hit hypothesis concept. So we do think that there are different stages along the way. There's psoriasis, then there's the preclinical PSA, where at the level of the synovium, you can see that inflammation has started, but there's no way to tell that without getting a synovial biopsy, for example. Then there's subclinical, where if you put an ultrasound probe on the patient's joint, you can see something, but the patient really still isn't feeling anything. And then what we call prodromal, which is kind of the phase where the patient's starting to feel kind of like stiff in the morning, but it's very non-specific symptoms. Maybe they even feel just fatigue or general achiness. That is where, right before they develop the kind of real PSA. So we know some of these things in pieces. So we know that subclinical PSA exists, or at least we're calling it PSA. Subclinical inflammation, the synovial enthesial complex is present, and some of those people go on to develop PSA. We know this prodromal phase from talking to our patients, because they'll say, for the last couple of months, I've just not been feeling well, and then the joint swelling started. Some people, it's very specific, like it just started one day when I woke up. So these are all things that we have to kind of put in context. And then what could be happening at each phase. So understanding the pathophysiology is a whole nother component of this process. So there's a newly funded, or actually now it's a year, funded AMP project through the NIH, so Accelerating Medicine's Partnership. AIM is autoimmune and immune-mediated diseases. So we are the psoriatic disease team, and this is part of what's happening in that disease team, is trying to sample tissue along the way to see what's happening at the different stages. So this piece still being defined, and so we don't know a lot about what's going on here. So in order to identify those patients who are high risk, we have to be able to define specifically high risk through either clinical epidemiologic methods or just clinical features of the patient sitting in front of us. It is important to understand, though, that there are risk factors and then there are predictors. So as an epidemiologist, I get hung up on terms like this because a risk factor is something that's etiologic. It happens way before things start. But the fact is that PSA, as I showed you on that paradigm, is starting way before we know that it's actually happening. So how do we know whether something's a risk factor? In reality, when we're trying to identify a high-risk patient, we just want a predictor. So it's something that's happened before the time that we want to identify them by. So as I talk about some of these things, if you're an epidemiologist, I'm not really specifically talking about risk factors that are etiologic. I'm talking more about how do we, in the EMR, let's say for that patient sitting in front of you, what codes need to come up in order to say this patient is high risk. And I mentioned clinical phenotypes because so far genetic risk factors haven't really been all that helpful in terms of sorting out who is going to develop psoriatic arthritis. There are some nice studies in journals like Science Communication, but they identify a very tiny portion of the population that is at risk. And when you look at genetic markers more broadly, these aren't really all that helpful. So we first started with a systematic literature review and looked at all the risk factors that had been identified, or risk factors, predictors. And I made these kind of categories here so you can see the numbers of studies that have been identified. So comorbidities that are happening before, so people tend to accumulate comorbidities like metabolic syndrome, for example. Obesity is a really strong risk factor in terms of both in terms of the effect size, but also in terms of the numbers of studies that have identified obesity as something that predisposes the patient to PSA. Smoking is light colored here because there's studies going each way, and we think that's probably not a risk factor. Trauma is something that happens often before people develop psoriatic arthritis. And from the Kebner phenomenon associated with psoriasis, so if someone scrapes their skin, they tend to get a psoriasis plaque around that area. We think that could be happening within the joint as well. Nail disease, maybe not because it's a true risk factor, but there's an enthesis right below the nail bed. So it might be that when you get inflammation there, you're getting a little stippling of the nail and the nail bed's getting affected. So it might just be a very early sign of someone who's got enthesitis. Psoriasis duration, probably not a risk factor specifically because people can develop PSA at any one time along the pathway. Psoriasis location and quality and psoriasis severity may be risk factors. So we recently published a study demonstrating that the more body surface area a patient has, their risk for psoriatic arthritis down the road is substantially increased. And I'll show you that in a minute. And then stiffness, pain, and fatigue, this is where we find that prodromal phase. There's a number of studies suggesting, finding that people are reporting those symptoms before they develop PSA. We've also identified that the PET score, so one of the screening tools, can be used as a predictor. So as the patient on the screening tool starts to add more questions, tick off more answers on the questionnaire, they are increasingly high risk for developing a diagnosis of PSA. So again, they could have it at that time. They're marking things off, but they're getting closer to their diagnosis as they mark off more things on their questionnaire. So as we talk about treating psoriasis and whether that would prevent PSA, we also have to understand the relationship between psoriasis severity and development of PSA. So this is something that I was really interested in for my K Award. I actually wrote about this topic. So this was one of the studies from the K Award in which we examined whether or not severe psoriasis was associated with development of PSA. One of the major confounders here is obesity. So I already told you that obesity is a known risk factor for psoriatic arthritis, and obesity is also strongly tied to the amount of skin psoriasis. It's a really interesting phenomenon that we don't totally understand, except for that we think that for some reason fat cells or adipocytes might have some extra impact for psoriatic disease as opposed to other inflammatory diseases. So as you increase body mass index, you increase body surface of psoriasis. And if you do bariatric surgery, for example, and the patient loses weight, they can also decrease their body surface area of psoriasis. So a very interesting phenomenon, but it makes it a very important confounder as well. So when we study this in a patient population in the United Kingdom, we took 10,000 patients with psoriasis in the UK in this group called the Health Improvement Network. It's a collection of primary care physicians, and they contribute data to this data source. It's essentially like Epic data. We are able to send questionnaires. So we sent questionnaires to the patient's GP to ask about their psoriasis severity. So we quantified psoriasis severity back in 2008 to 2011. We sent questionnaires over the 3-year time period to these general practitioners. And then we watched these patients forward in time to 2015 when we cut the data. We'll be doing another analysis through 2021 soon. So this was the results of that prospective cohort study. So among the patients who had a moderate body surface area of 3 to 10% of their body covered, and this was about a quarter of the patients, they had an increased risk for psoriatic arthritis of about 1.55. So about 50% increase in the risk for PSA compared to someone with mild disease. But if you had severe psoriasis, so greater than 10% of your body surface area covered by psoriasis, you were 2.4 times as likely to develop PSA over time. And this was significant even after adjusting for other things like obesity. So you see obesity was still significant and increased the risk by about 60% as well. The other interesting one is depression, and this had been shown prior to this study as well, but we wanted to see how this had an interplay. And you can imagine that as you have increasing psoriasis severity, it's depressing. It feels terrible. People see it, they ask questions about it. People still ask ridiculous things about whether or not it's, they're going to get infected from touching the patient or being near the patient. So that can be depressing. In addition, obesity is also strongly associated with depression as well. So, but depression was an independent risk factor in this particular study as well, even after adjusting for body surface area and obesity. So we then looked at the interaction between these two. So does it matter if you're obese and have severe skin disease compared to if you don't have either or one of the two? And it turns out that patients with severe psoriasis and obesity had a substantially increased risk of about almost 4 times the risk of the patient population without either of those. And that moderate psoriasis and obesity was about 2 times. So you can see that there was some increased risk, even though the statistical interaction was not statistically significant. But how helpful are those predictors? Well, even when you combine all 3, obesity, severe psoriasis, and depression, while the hazard ratio looks really strong, you're only identifying about 8.5% of patients who are likely to develop PSA. So the positive predictive value still isn't that good. So that alone can't really identify a high enough risk that you would go around treating all of those patients. Through a number of other studies, though, we've identified other potentially actionable risk factors beyond psoriasis and obesity. Hyperlipidemia, maybe, depression, maybe. Infections do stimulate inflammatory disease activity. So maybe, but we can't really, would treating with antibiotics help or not treating with antibiotics help? We don't really know. Alcohol does seem to be a risk factor. So if you could tell a patient with psoriasis not to do these things, they may have a decreased risk, but we don't know. One study in the UK just looked at an observational evidence for this, and they found that among patients who lost weight, who are obese, they decreased their risk over time for PSA. So there's some suggestion that if you could get an obese patient with psoriasis to lose weight, they may reduce the risk for PSA, which actually makes a lot of sense. We know that reduces the risk for osteoarthritis as well. But can we actually treat patients with biologics and think about developing randomized controlled trials to do that? So before we planned a randomized controlled trial, we needed to first come up with evidence that suggested in observational data that this would work. Because if it didn't, would it be worth planning a trial? Well, there's a few things about observational data that make this a little bit of a problematic question to study in observational data. First, people get biologics for very different reasons than they get an oral therapy or phototherapy. So if you have psoriasis and you're seeing the dermatologist, what helps make that decision? Well, it's the patient's, desire, how bad is that psoriasis bothering them? There are some people with really bad psoriasis that are not bothered at all by it, and they're happy just to keep doing what they're doing. On the other hand, there's some people with very little psoriasis, but in very impactful areas, let's say like the scalp or the genitals, and those people are highly impacted by the psoriasis. And so they may be more likely to choose therapy. Dermatologists may be more likely to put someone with really severe psoriasis on a biologic than someone with mild psoriasis on a biologic, which makes sense too. So these make these people kind of apples and oranges. It's really hard to directly compare them. In epidemiology, we have these things called directed acyclic graphs that help us think about what are all the things that go into making a treatment decision, for example, and how might we manage those in a model. So when we were thinking about this, we were thinking, what influences therapy provided by a dermatologist for a patient with psoriasis, and whether or not that's associated with psoriatic arthritis diagnosis. Well, I have spoken to some of these. Some of these are the patient factors. Comorbid conditions, dermatologists tend to be relatively risk averse. And if there's more comorbid conditions, they may not prescribe therapy, or at least biologic therapies. Prior therapies are going to determine a subsequent therapy, which makes sense. How much fatigue a patient has. Patients come in with lots of fatigue and they say, my psoriasis is really making me tired. That might make the dermatologist more likely to prescribe a biologic, or the patient more likely to ask for a biologic. Psoriasis severity, dermatologist preference. There's some dermatologists who just don't prescribe biologics. They are much more in the cosmetic area or other areas, and they're just not doing that. And we know that from data. Dermatologist access is hard. So if you've tried to get a dermatology appointment, you know how hard that is. And so for our patients who have less, know-how about the system and how to migrate the system, getting a dermatologist appointment is really difficult. Now, how do arthrologists affect that? Well, we know from talking to dermatologists that if a patient has psoriasis and they're having arthralgias and they know it's a long time to get into rheumatology, they just go ahead and prescribe a therapy that's going to cover both. And then they say, just go see the rheumatologist. And if you're the rheumatologist, you're like, oh, I really would have loved to see them when they actually had active stuff going on, because now I can't see anything. But we acknowledge that it's hard to get into us, and that's a reasonable thing to do. But having arthralgia is also associated with having PSA. So you can see that this could be a potential confounder. Additionally, rheum access is really hard. And when we're using data sets, getting a diagnosis of PSA is really a surrogate measure of whether or not you actually have PSA. So while they could be closely related, they're not always a perfect assessment. So over the last 2 to 3 years, actually about 2 years now, there's been several publications about biologic therapy for psoriasis and development of psoriatic arthritis. There are 3 studies that suggested that treatment of psoriasis with a biologic therapy was associated with a reduced risk for psoriatic arthritis. And these were all single center studies using their equivalent of EPIC. 2 of them were derm-rheum collaborative cases or studies. So, if the dermatologist wasn't sure, they could ask the rheumatologist counterpart to take a look. None of them had exams, though, prior to starting the biologic therapy. And then there were 2 studies that suggested that biologic therapy was associated with more psoriatic arthritis. Actually, one of those was ours. And so we don't think by any means that biologics cause psoriatic arthritis. We do think that there are biases in the data that are making it look like that, specifically that last piece about dermatologists treating psoriatic arthritis, not labeling it as such, and then they later see the dermatologist after they've gotten the biologic therapy. So that could account for some of them. So I won't spend too much time on the individual study, but I will show you that first, about 14,000 patients out of almost 200,000 patients with psoriasis got a biologic therapy during this study. You could say that's actually not a lot. And we know that about 10% of patients with psoriasis are actually treated with biologic therapies. That's probably inappropriately low. So there's probably lots of patients with psoriasis who deserve a biologic therapy that aren't getting them. But in any case, it is important to note that as we think about some of these studies. One of the interesting things is when you break down incidence of psoriatic arthritis among people on different therapies, we see higher incidence for anyone getting a biologic therapy compared to no therapy, or all people in the cohort, which is about 10 per 1,000 patient years. For biologic therapies, it's about 77. For TNF inhibitors, about 83, and IL-17 inhibitors, about 78. So these 2 therapies are highly effective for psoriatic arthritis, so they're PSA treatments. But you see a lower incidence for interleukin 12 and 23 inhibitors. And that's probably because we don't really think of those as highly powerful psoriatic arthritis treatments. We think of those as really good psoriasis treatments. So if you're a dermatologist and you're sitting with the patient and they're complaining of joint pain, you're going to choose one of these other therapies that really work for the joints well, as opposed to ustekinumab maybe, which is potentially lower effectiveness for the joints. So we think that that kind of points to that, what we call protopathic bias, where you're seeing something in the data, but what you're not capturing is what's happening in the clinic room, and that the patient is being treated for the outcome of interest before the outcome of interest shows up in the data. So it looks then like patients who got a biologic therapy are statistically more likely to develop PSA. But what's really happening is that most of those people are finally seeing someone who's giving them a diagnosis of psoriatic arthritis within 6 months to a year of when they got that biologic therapy, which makes perfect sense because that's about how long it takes to get into a rheumatologist. So we don't think that biologics cause psoriatic arthritis. We think that we're not able to see that in these large data sets. So there's lots of biases in observational studies. So prior to the pandemic, not many people knew what an epidemiologist is, but now people actually do know what an epidemiologist is. But the definition that was, I like this meme, an individual who does precise guesswork based on unreliable data provided by those of questionable knowledge. So not that dermatologists have questionable knowledge, but they do have questionable coding skills. And so we did find in a subsequent study that when you look at who's putting in codes for musculoskeletal disease or any musculoskeletal condition or even inflammatory arthritis. So musculoskeletal disease in red, yellow is inflammatory arthritis. Here's dermatology, it's psoriasis and rash. So there's not a lot of in between there, but there's this tiny sliver of patients who has a code for psoriatic arthritis. So what we really found is that you can't rely on data from dermatologists and large epidemiology studies to make conclusions about whether or not biologic therapies improve the likelihood of developing psoriatic arthritis. And you all are, I'm sure, familiar with lots of the different limitations of retrospective observational studies, but we rely on codes, their associations, not causation, observational bias, misdiagnoses, and then missing data, because some of these people float in and out of systems. So we have to be careful with assuming that we have information about what's happening all along the way. All right, so we decided to go ahead and plan a trial anyway about treating psoriasis and whether or not that would prevent PSA. One of the problems, though, is that very low incidence of psoriasis or psoriatic arthritis. So we had to think about ways of increasing the likelihood that we're capturing people maybe later down this spectrum a little bit, so that we know that there's a high enough likelihood that those patients are going to develop PSA that we can see it in a trial. Because if you enroll patients way back here, we'd have to follow them for 5 years at a minimum and thousands of patients with psoriasis. And when you're talking about really expensive drugs, that's just not feasible. So we decided to start in this kind of middle zone here of subclinical PSA. And in this trial, we're taking patients who are screened at baseline who have psoriasis and no diagnosis of PSA. They don't have joint pain. We do an ultrasound of joints and theses, identify people who do have ultrasound evidence of inflammation, and then they are then randomized to guselkumab or placebo. Because they could be randomized and we're not sure, a lot of people don't want to be randomized and have a chance of getting placebo for 6 months. We have this observational arm where they're just treated by standard of care, but you go through all the same assessments. And we did this because we think it's really important not to lose people, because one of the problems with trials is that we're studying the ideal patient population. And we don't know about what's happening for the whole generalizable population. So we want to get as many of those people in to that other arm as possible, so we don't lose people that we're screening. So these patients will be treated with guselkumab versus placebo. The primary endpoint will be change in ultrasound at 6 months, as well as a proportion of patients transitioning to PSA at 2 years. So lots to still learn, but we're on the path. We have a road we've paved, and so we're starting to walk down that. And this is going to be a first trial. Won't answer all the questions that we needed to answer, but at least we're on the road. And the ball is rolling. So while there's insufficient data to suggest at this point that treating psoriasis will improve the risk for PSA, we're hoping to get more answers with all these different studies that are ongoing. So lots of people involved in this. This is definitely not me, but this is a team of people that are doing all this work. And we really have fun together doing all this work. So I definitely appreciate everyone and the funding from NIH, National Psoriasis Foundation, and a variety of pharmaceutical companies too. With that, I will stop and open for questions and discussion.
Well, thank you for a fantastic presentation and overview. At this point, we'll take some questions from the chat if there are any. I think and then we'll take questions from the audience here as well. Maybe as we're getting started, I actually did have a dermatologist who was online who followed up with me as well and said, do you have any advice? He did make the point of, general rheumatologists don't see a ton of these patients and they have really quick visit times. But if you had a specialties psoriasis clinic, what's sort of a good screening questionnaire for more focused clinics?
Great question. So the PEST screening tool, PEST, is available online at National Psoriasis Foundation or other places. It's 5 questions. It's really easy.
Okay.
If they get a score of 3 or more, they should probably see a rheumatologist. It's not specific in that those patients could have osteoarthritis or gout, or, but they have some kind of arthritis that probably should be seen.
Perfect. That's great. Other questions in the room? Yeah. Dr. Brad Astor. Also a hero epidemiologist. How about
Awesome.
that?
Okay.
It was an excellent talk. A couple things. Does the first presentation, you had, I don't know, 8 or 10 different things up there. Are those correlated with risk or with eventual outcomes? And then the other thing, one of the last slides, you had an observational arm attached to a randomized trial. How do you present that? And do you think having that third arm actually detracts from enrollment in the trial?
So I'll take the second one first and then go back. So it could detract. It is presented as this is a trial and the chances are to receive guselkumab or placebo. And if they say, I don't know, and if I really want to do that, then you say, well, there's this other arm where we can just follow you. Would you be willing to do that? So it's kind of presented as an alternative. It may, so far though, actually the randomization into the trial has predominated. So there hasn't been anyone that's selected is early. There's only like 25 patients enrolled so far, but so far, all of those patients have chose to be randomized. Oh yeah, sorry, the initial presentation. Do you mean the different risk potential actual, is that what you mean or?
No.
Oh, yes. Got it, like the different disease features. And I'm sorry, what was the question? How do they?
So is this just a random or type of disease severity?
Great. So is it meaningful in disease severity? Yeah, so it is not necessarily, it is random. So some people present with each one of these. So it's really hard. Actually, axilla disease as a presentation ends up sometimes making you into axial spondyloarthritis with psoriasis. There's some funny things there that kind of just shifts where you get who sees you first or what you're kind of being labeled as. But dactylitis is a common one first, but so is enthesitis, so is peripheral arthritis. So it just depends. And does that have meaning for long-term? So dactylitis is and polyarticular presentation suggests more aggressive course of disease. But other than that, there's not a lot known yet. Actually, one of my mentees just got an excellent score on his K award to look at clusters and how that actually may inform outcomes.
I take one from online and I'll come right back. So online, we've got 2 questions, actually, one from Dr. Amy Malik, one of our pulmonologists, and she's asking about associations between psoriatic arthritis and osteoarthritis.
Yes, that is really tough. So osteoarthritis is the great masquerader of psoriatic arthritis. So we often get a lot of patients who failed multiple therapies. And when we look at their hands or do an ultrasound, it's really erosive osteoarthritis. So that's a really tough one to separate out. As sometimes we're still not sure sometimes whether that's psoriatic arthritis or osteoarthritis, but it's just very common anyway. So osteoarthritis is common in anyone. And so you have the 65-year-old patient with psoriatic arthritis, they likely have osteoarthritis as well. So what I really encourage is people to look for the swelling. So you got to have swelling or something on ultrasound that suggests synovitis. We have realized that some of our radiologists who do ultrasound call osteoarthritis synovitis sometimes too. And so it does conflate the two a little bit more. We have a rheumatology ultrasound group, which has been much more helpful in terms of sorting those things out because you can put the clinical context with it. So it's very difficult. I think that's one of our biggest challenges in psoriatic arthritis is sorting out what's osteoarthritis and what's psoriatic arthritis.
Yep, thank you. And just to expound on that, I'm early on in my career, but I've really been blessed here to be have a couple of colleagues who do MSK ultrasound, and also been really humbled by what you'll pick up. And so for patients who are being evaluated for psoriatic arthritis, should all those people be getting an MSK ultrasound if we can't see synovitis on our exam?
Yeah, so I do refer a lot of people to ultrasound if I see nothing on exam. So I'm either going to watch and wait or refer for ultrasound, because I wouldn't treat anyone for psoriatic arthritis unless I see something.
Great question. We've got a couple of great questions in the chat. One of the questions is from Dr. Sanchita Ferguson, one of our rheumatologists as well. And thank you for that terrific question, Dr. Trevor McCown, one of our other terrific rheumatologists, many in the room here today. Dr. Ferguson was asking the question of whether maybe use of agents such as methotrexate with questionable impact on psoriatic arthritis are actually pushing towards the phenotype of psoriatic arthritis. Sort of, do you have any thoughts on that based on what you've seen?
Yeah, that's a really good question. So if you're treating psoriasis with methotrexate, and then, so interestingly, dermatologists don't do that much anymore. So I think dermatologists are much more afraid of methotrexate than they are of any of the biologics. So I think we've seen a big shift away from that, especially as the interleukin-23 inhibitors have come. So it does raise big questions though. Yeah, if you're treating the skin, but not the joints, are you going to prevent it? Well, there have been some studies suggesting that in murine models that skin cells get activated, like some T cells that can actually travel through lymph nodes into the synovium. So there may be mechanisms that if you are shutting down the inflammation in the skin, you could prevent that from happening. And so that's where maybe effective treatment of the skin, like through an IL-23 inhibitor, for example, may reduce the likelihood of something like that happening. But if that's already happened and that you already have that preclinical phase where there's synovial inflammation that's starting, and interleukin-23 may not shut that down, because now we're in the phase where it's TNF, IL-17, and so on. So, but IL-23 does work for psoriatic arthritis too. So I think there's a lot of questions about all these mechanisms and how they play different roles and how shifting the immune system has an impact one way or another.
At one point I looked with, I think there was 117 people online. I don't know earlier, but we've got a number of questions in the chat. So one of the other questions that was in the chat, or two of them, I'm actually going to pair them together. We're just asking, I think, also about any other disease associations and or extra-articular features. So there's one question about any associations with type 1 diabetes. And there was another question on, are there any associations with interstitial lung disease and psoriatic arthritis in contrast to RA?
Great question. So RA has an association with type 1 diabetes sometimes. So that's more in the autoimmune. So now we consider psoriatic arthritis, axial spondyloarthritis, inflammatory bowel disease, and psoriasis to be more immune mediated conditions. So psoriatic arthritis and psoriasis specifically have association with type 2 diabetes and metabolic syndrome. So we see a lot of fatty liver disease, obesity, cardiovascular disease. Actually, psoriasis is considered an independent risk factor for cardiovascular disease, psoriatic arthritis too, but maybe to a lesser extent than severe psoriasis. And that's in the ACC guidelines. So those metabolic conditions and cardiovascular disease are strongly associated with psoriatic disease. Psoriatic arthritis is associated with inflammatory bowel disease, uveitis, Crohn's disease more strongly than ulcerative colitis, but you can still see ulcerative colitis. Other conditions, depression, just in terms of other comorbidities, depression and anxiety are very common. About a third of patients at some point in the course of their disease, and that was pre-COVID, those estimates. So I think post-COVID, we see even a lot more of that. But those are very common as well. And fibromyalgia, up to about 20 to 30% of our patients have concomitant central sensitization or fibromyalgia as well. Interstitial lung disease, not an association with psoriatic arthritis specifically. That doesn't mean, I have seen those patients. But theoretically in large data sets, it doesn't seem like it, although that specific study hasn't been done well. So I will say that there's an opening for better understanding that. In AxSpA, we've seen some of that. We have seen an association between COPD and psoriatic arthritis, and that's not totally clear.
Hi, I'm Giancarlo, one of the residents here and future rheumatologists. Anyway,
Right.
I was just going to ask, are you aware, or is anyone in your team at Penn doing any, banking of microbiota samples, especially early disease or prodromal or even earlier than that? And then, of course, with disease, yeah.
Great question. So microbiome is a hot topic, and Jose Scher is one of my closest collaborators at NYU, and that's his thing. So, but we have two things that are going on right now. One is the AMP study that I mentioned. AIM Psoriatic Disease Team is collecting microbiome at all kinds of points. So stool primarily, but also skin samples. And then there's a talk of saliva microbiome. I don't know much about that, though. I just heard about that the other day. So that is being collected for those specific studies. We're also running a dietary trial because of this whole concomitant metabolic disease component and the impact of obesity on the level of disease activity as well as on therapeutic response. So we are randomizing patients to one of 3 diets and then following them over 6 months. But we're taking microbiome specimens prior to the diet at 12 weeks and at 24 weeks. So down the road, we'll see what that looks like.
We have a parallel question in the chat. Thank you for that terrific question. They were just asking specifically about an F to B ratio in microbiota, and I'm not familiar enough to say anything more about that. So we could go to the next question. Okay. Okay.
Oh, cool.
Okay.
So let me. F to B ratio. There are differences, but I would have to pull up Jose's paper or ask him to describe that because I can't even say half those words. So
Great. No, terrific. Good, but good domain for further research. There's another question in the chat that was asking about prior activity, saying that would people who did weightlifting or other kind of spinal loading activities, is there any known association with, I think it's probably prior joint trauma?
yeah. That's a great question. So there was one study from one of the Scandinavian countries examining like load essentially on your back. And so they were looking at different types of work, for example, and the association with axial spondyloarthritis damage. So it was among patients with AXSPA, and they found that there was a potential association with having more of a manual labor job and worsening disease. You can think of all kinds of reasons that might be true, though. So we, from socioeconomic status to other things. So we don't necessarily, we tell people exercise is very important. And I am a very firm believer that we need our patients moving and to have nice, strong muscles around those joints to help support the joints and to not allow for too much fat within the muscles, because then that furthers the metabolic syndrome problem. So while that may be a risk that there's trauma, repeated trauma, for example, we tell people to exercise. Now, if someone was like a, can't remember that kind of lifting they do with this, power lifter. So maybe not the best thing for your back anyway. So, you could imagine that there could be mechanical back pain problems. You could be getting degenerative disease or disc disease. So, you might avoid some of those things that are generally not going to be the best for your back if you have an inflammatory disease as well. But I don't specifically counsel against those things, especially in people who are doing that over a long period of time.
Got one other question in the chat here asking, are there any identified risk factors for development of uveitis and psoriatic arthritis?
So uveitis is actually one of the strongest risk factors for development of psoriatic arthritis going the other way. There are not necessarily identified risk factors for development of uveitis. I think if you have IBD, it does raise the risk. So if you already have psoriasis or psoriatic arthritis and you have Crohn's disease, your likelihood of developing uveitis is probably higher than the person without Crohn's disease, but not really quantified. I feel like I saw a paper like that relatively recently, but I don't know if there's been anything more recent.
I want to thank everyone and particularly Dr. Ogdie for a robust conversation that spanned everything from eye disease to skin disease to arthritis this morning, and the microbiota. How about that? So thank you again. And I'll just ask the crowd to just go ahead and give a warm applause and thank you so much for this fantastic job. We'll stick around for a few questions if there are any after the talk, but thank you all.
Thanks so much for having me.